Now I have a whole group of people that go out like emissaries and actually talk to the physicians as well as talk to patients, friends, family, neighbors about the latest standard of care in treating the tobacco addiction. And in actuality, the latest standard of care is we are now recommending 2 different kinds of nicotine replacement therapy at the same time. A patch that we slap on them for 24 hours, and PRN gum, lozenges, inhaler, whatever. And I'll tell you more about that. But that is the latest standard of care. And when we have them use the nicotine gum or the lozenges, we're talking about they can use up to 10 to 15 pieces a day if they need it, in addition to a patch. The key is just like taking away pain, okay? The key is taking away the desire to smoke. And that is what we're taking away the withdrawal symptoms. That is what we're looking for. It's like treating any other addiction. By the way, is there anybody in the room, show of hands, who believes that tobacco use is not an addiction? Well, that's fantastic. Of course, all of the evidence now does show that tobacco use is an addiction, specifically cigarettes, of course. And in fact, the addiction is so potent that it is just as potent as cocaine and heroin. Same pathways are involved in the pleasure mechanism of using tobacco. And as a matter of fact, those of you that have dealt with addicts, they're always an addict, they just may be in recovery, of course. Those of you that have dealt with addicts, a lot of times, I have a number of addicts in my practice, and they're still smoking. But they're clean of drugs, but they're still smoking. And I asked them that, I said, which is harder? Getting clean of drugs or getting clean of smoking? And their answer to me is, well, how about if I tell you, doc, that I'm still smoking? Does that answer it? So this is a tremendously powerful habit and addiction. It's a combination, I'll mention that. Basically, the national CDC said recently that the national numbers of tobacco use is down to about 18% of the population. I'm not going to go into all the details of numbers and demographics and stuff, which I use on other presentations, and I'm just going to try to hit the highlights in these 40 minutes. I am always available to speak to groups, to speak to people. I'll talk to you individually. I'll come to your house. It doesn't make a difference. I'll talk to anybody about trying to get people to stop smoking because of the terrible stuff that it's causing all of our patients and how many diseases are associated with it, and how we can help people by getting them to stop smoking and also ease pain and suffering. Greatest thing, I woke up one morning the other day, and this is what I read on the front page in the New York Times. And as I'm yes. So, and obviously CVS is going to be taking all the tobacco products off their shelves. And of course, I have no doubt that in the next 12 months or 18 months after that, you're going to see Walgreens next, and you'll start to see them tumble like dominoes as tobacco gets taken off the shelves of all of these, certainly pharmacies first. A couple of words about the Area Health Education Center called the AHEC. There are AHEC programs around the state and around the country. We have an AHEC over at Nova Southeastern. University of Miami has an AHEC. The AHEC at Nova Southeastern, where I teach, actually does have an affiliation with Memorial in terms of offering teaching and tobacco cessation classes. And these tobacco cessation classes which are offered are free, and also nicotine replacement therapy is given out for a number of weeks at these classes. One of the great things about the program that the AHEC has is that you can give this phone number, that's that 1-877-848-6696 number, to your patients, friends, family, and what happens if they call that number, they will be referred to tobacco cessation services in their county, wherever they live. It's a fantastic program, it's a fantastic service, and the classes are really fantastic. We have these classes at Nova. They're run by the psychology department, and they're like an hour a week for 6 weeks, and they're really I've had a number of patients that have come back from those classes and have stopped smoking. I dare say I probably have at least 1 or 2 people a week that stop smoking as a result of the classes that are offered. They're absolutely fantastic. By the way, the current standard of care, in addition to double nicotine therapy, is counseling plus medications can double your chances double the patient's chances, the client's chances of long-term cessation from tobacco products. This is very powerful because a lot of people don't know that. And so what happens is that you get your patients into these classes, and we get them on medications. Why on medications? Because remember, it's an addiction. And just like we treat any other addiction, you stop the addiction, you're going to withdraw. And we have ways through the nicotine therapy to handle the withdrawal symptoms. You know, we hear stories about people saying the only way to do it is cold turkey. Only about a small percentage of people that try, about 4 or 5% of the successful people actually do it cold turkey. By putting people on double nicotine therapy and counseling, you can actually double that to maybe 30 to 40% success. I mean, it would be nice if it was 80, but this is hard stuff. And remember, it's an addiction and a behavior. And this is the State of Florida quit line. State of Florida quit line is very valuable also. Your patients can call this quit line and they will receive essentially counseling over the phone. It can be arranged at a convenient time, sort of anonymously, if you will, because they don't have to look at anybody face to face. And it can be done in other languages. They use translators, and they will set up counseling for other languages if necessary. I had a patient about a year ago that their family helped get them to the counseling on this line. And it was Portuguese was the language that this lady spoke. And they arranged to have people who spoke Portuguese do the counseling. So it's really a tremendous program as well. A couple words, of course, about tobacco and cancer. These are some of the diseases, some of the cancers and chronic diseases that we see in tobacco use. Obviously, we know many of these, everything from stroke, congenital defects, obviously cancers of the mouth, of the tongue, of the lungs. I don't have to go into all of them, but of course you see other things that we're talking about. The latest stuff now is diabetes, obviously also cancer of the pancreas, and we know about all the other chronic diseases. You know, a lot of our patients, when we ask them, well, what do you know about smoking and the risks, and they know about lung cancer, they may know about heart disease, they may know about stroke, but they don't know about these other diseases that we're talking about. I give presentations to the School of Optometry and optometrists in the community, and I try to explain to them that they have the ability to also have a teachable moment to their patients who smoke, because many people obviously get an eye exam every year, and of course that is a perfect time to do a teachable moment. Dentists the same way. That's also a perfect time to do a teachable moment. Have their dental hygienists help out and give them a mini presentation at that time. So a couple words about nicotine. This is what does it. Nicotine, which is obviously, nicotine is the hook in tobacco. It's the hook. Nicotine by itself doesn't kill people. What kills people are the 6,000 plus chemicals that are in smoke, plus the 60 carcinogens. But nicotine is the hook, and the more nicotine they put in the cigarettes, the greater the hook, the harder, the tougher the addiction. So, nicotine is also psychoactive. We know that. We know that when people smoke, they enjoy it, they feel better, they have all kinds of good feelings. It's a euphoriant, we know that as well, and it's also a reinforcer. Now, just for 1 second, think about, if you will, think about somebody who smokes 1 or 2 packs a day for 20 years. Now, you want to talk about a powerful reinforcer. Think about that hand-to-mouth activity over 20 years. If you do the math, if you break it down and you do the math, you're talking over 10 million hand-to-mouth actions in perhaps a 20-year smoking 1 to 2 packs a day. Maybe 10 million, it may be more, but it's at least 10 million hand-to-mouth, hand-to-mouth, hand-to-mouth. You want to talk about something that's a reinforcer. That is absolutely unbelievable when you think about it. This is a little chart of nicotine distribution. This shows you what happens after you take a puff on a cigarette. You see that there is an immediate surge of nicotine, giving you a high arterial level. Then, of course, then it goes down after about 10 minutes, but it stays fairly flat for the next couple of hours. That's why every couple hours somebody needs to go outside and have a smoke. By the way, what do we call that in the business when people need to go outside and have a smoke? We call that presenteeism. We know what absenteeism. Presenteeism is when you have people that come to work and every couple hours need to go somewhere to take a smoke. That's presenteeism, okay? And if you think about it, it's interesting, at Tampa General, what we started doing for a while, which is where I was before I came here, at Tampa General, we started giving nurses water bottles. And so just to give a little parody of some of the nurses that were going out to smoke, we had the other nurses have their water bottles and go for a water break, for sort of equal parity. It was an interesting concept. So here's a little cartoon of what happens. What is it that causes what is it that causes people to enjoy smoking? And what it is these little granules here that we call dopamine. Dopamine is a neurotransmitter. When a person takes a puff on a cigarette, here you have the nicotine molecule. This nicotine molecule attaches to this little receptor here called the alpha-4 beta-2 receptor. Okay, and this happens, in the brain. That alpha-4 beta-2 receptor, which is then being stimulated by the nicotine, causes the production of dopamine. Dopamine is what makes people want to smoke, because dopamine causes all of those wonderful things. And so dopamine causes, now this is the opposite of what dopamine causes, but dopamine causes increased concentration. It causes relaxation. It causes you to not be anxious. It causes you to have increased concentration, be less restless. And then conversely, these are the things that you see when people try to stop smoking. Are there any people here who are ex-former smokers? Raise your hands if anybody's a former smoker. Can any of you identify with any of these things that occurred when you tried to stop smoking? And obviously this is what makes people not want to be around other smokers when they're trying to stop smoking, of course. And but these are the things we see. And then of course these are the things that make people really want to smoke. Those of you that have spent time in CCUs, this is a really interesting statistic, piece of information, little factoid. You take a puff on a cigarette, that nicotine hits the brain in 8 seconds. It's like pushing morphine. 8 seconds. It is an incredibly powerful delivery system. That pulmonary delivery system is unbelievable. 8 seconds, it blasts into the brain, causes dopamine production, and then all the relaxation and wonderful things that we see from the wonderful things that the patients see from tobacco use becomes active. I wanted to talk about, this is the healing timeline. I know that there have been some questions, and this is like the question we get all the time as clinicians. If I stop smoking, how long before my lungs are normal? How long before they're back to where they were when I was 17 years old and I was running 10 miles? The answer is when people stop smoking, the risk of lung cancer never really goes down to 0. Okay, and that's a little, sometimes it's hard to swallow. And the reason for that is we believe there are DNA changes that occur in the lungs that are as a result of the thousands of chemicals and the products of combustion from tobacco use. And so it never goes down to 0. However, the mortality rates as a rule, and I don't know if you can see that down there, the mortality rates do, as an overall rule, come down to non-smokers between 10 to 15 years. So in 10 to 15 years, if the average person, if they are lucky, basically will have a mortality basically the same as somebody who is a non-smoker. And you can see the other ones here. When somebody stops smoking, within 20 minutes the BP comes down to normal. Within 8 hours, the carbon monoxide in their lungs, in their blood drops to normal, sorry. Within 24 hours, sense of taste and smell is better. By the way, that's one of the possible suggestions as to why people gain weight when they stop smoking, is we think that perhaps, and it's happening subconsciously, but we think that happens because your sense of taste and smell are better. People are eating more. And you know, it doesn't take much more eating every day over the course of several months to put on 10 to 15 pounds that maybe are the average that smokers talk about when they stop. So that's that. 9 months, coughing, congestion have dramatically decreased. One of the things people will tell you is that their exercise tolerance seems to be better at about 9 months. 1 year, risk of heart disease cut in half. 5 years, stroke risk equal to non-smoker. 10 years, cancer of throat, lung, mouth are basically cut by about 50%. Also, heart disease risk actually comes down to dramatically decreased in between 10 to 15 years. I have to tell you, if I have a patient that doesn't want anything else from me, that doesn't want to talk about tobacco cessation, I ask them, may I give you one piece of paper to put up on your refrigerator? And I give them this. And there are, this is very, very powerful. So if I get somebody that says, I don't want to talk about tobacco cessation, okay? Then can I give you this? And maybe next time we'll talk about it. And it's interesting, people will accept this. How many times do we give people packets, folders of stuff? And I walk out of the office and there's a garbage can near that, and all of a sudden you see these folders sitting in the garbage can. So you look at them and you say, are they clean? Yeah, okay, take it and I'll put it back in there. So, but it's a reality. I mean, to give these major folders, you know, so that's why sometimes less is more. Works for everything else in life, right? Sometimes we give them less, it's a little better. You want to give them stuff they can read, stuff that they can identify with, stuff that they can enjoy. It's a reality. So, Dr. Block is going to speak about this. This is one of my favorite latest things that I talk about at conferences when I speak to docs. The latest stuff about who gets screened for lung cancer, what are the statistics on that. This is an article that just came out recently in the Annals of Internal Medicine. For those of us that are internists, this is like the internal medicine Bible. In 2008, the Surgeon General and the U.S. Public Health Service Task Force came out with special guidelines on what should we be doing about tobacco diseases in an office, in any office, irrespective of what you do. And basically, these are some of the conclusions: that multiple attempts to quit tobacco use may be needed. Anybody in the audience, anybody have an idea on an average how many attempts people need on an average to actually quit smoking? Yes? 5? Okay, 5 is in there. Anybody else? How about maximum attempts? Somebody say 50? If you ask Mark Twain, he said, it's the easiest thing I ever did was quit smoking. I've done it over 150 times. But in reality, in actuality, the average numbers are 5 to 11. That's the range. Why is that important? It's important because somebody who fails 1, 2, 3, 4, they don't feel like a failure. Or somebody who relapses, that's the right word, correct. For us talking here today, relapse is the right word. We don't like fail, but I'm using it for the sake of conversation. So here's an example that I like to use, okay? You know, kids are getting blasted with tobacco cessation in schools, right? We're going to middle schools, we're sending med students. We used to send rats, now we send the med students, because there are some things you can't force the rats to do. So these kids go. Now these young kids in middle schools, they're getting blasted with this stuff about tobacco, and this is great. You know why it's great? It's great because 90% of the people start smoking before 19 years old. If we can get them when they're young, if we can get them when they're in middle school, if we can get them before they leave home, either to get a job, to go to school, whatever, if taste and smell is better. By the way, that's one of the possible suggestions as to why people gain weight when they stop smoking, is we think that perhaps, and it's happening subconsciously, but we think that happens because your sense of taste and smell are better. people are eating more. And you know, it doesn't take much more eating every day over the course of several months to put on 10 to 15 pounds that maybe are the average that smokers talk about when they stop. So that's that. 9 months, coughing, congestion have dramatically decreased. One of the things people will tell you is that their exercise tolerance seems to be better at about 9 months. 1 year, risk of heart disease cut in half. 5 years, stroke risk equal to non-smoker. 10 years, cancer of throat, lung, mouth are basically cut by about 50%. Also, heart disease risk actually comes down to dramatically decreased in between 10 to 15 years. I have to tell you, if I have a patient that doesn't want anything else from me, that doesn't want to talk about tobacco cessation, I ask them, may I give you one piece of paper to put up on your refrigerator? And I give them this. And there are, Sherry, would you be able to address the issue later of where they can get copies of this? But there are copies of this available in a nicer form that they could put into a sheet protector and maybe put up on their refrigerator. This is very, very powerful. So if I get somebody that says, I don't want to talk about tobacco cessation, okay? Then can I give you this? And maybe next time we'll talk about it. And it's interesting, people will accept this. How many times do we give people packets, folders of stuff, and I walk out of the office and there's a garbage can near that, and all of a sudden you see these folders sitting in the garbage can. So you look at them and you say, are they clean? Yeah, okay, take them and put it back in there. So, but it's a reality. I mean, to give these major folders, you know, so that's why sometimes less is more. Works for everything else in life, right? Sometimes we give them less, it's a little better. You want to give them stuff they can read, stuff that they can identify with, stuff that they can enjoy. It's a reality. So, Dr. Block is going to speak about this. This is one of my favorite latest things that I talk about at conferences when I speak to docs. The latest stuff about who gets screened for lung cancer, what are the statistics on that. This is an article that just came out recently in the Annals of Internal Medicine. For those of us that are internists, this is like the internal medicine Bible, this journal, and so this is a great article, and I know he'll be addressing that. In 2008, the Surgeon General and the U.S. Public Health Service Task Force came out with special guidelines on what should we be doing about tobacco diseases in an office, in any office, irrespective of what you do. And basically, these are some of the conclusions: that multiple attempts to quit tobacco use may be needed. Anybody in the audience, anybody have an idea on an average how many attempts people need on an average to actually quit smoking? Yes? 5? Okay, 5 is in there. Anybody else? How about maximum attempts? Somebody say 50? If you ask Mark Twain, he said, it's the easiest thing I ever did was quit smoking. I've done it over 150 times. But in reality, in actuality, the average numbers are 5 to 11. That's the range. Why is that important? It's important because somebody who fails 1, 2, 3, 4, they don't feel like a failure. Or somebody who relapses, that's the right word, correct. For us talking here today, relapse is the right word. We don't like fail, but I'm using it for the sake of conversation. So here's an example that I like to use, okay? You know, kids are getting blasted with tobacco cessation in schools, right? We're going to middle schools, we're sending med students. We used to send rats, now we send the med students, because there are some things you can't force the rats to do. So these kids go. Now these young kids in middle schools, they're getting blasted with this stuff about tobacco, and this is great. You know why it's great? It's great because 90% of the people start smoking before 19 years old. If we can get them when they're young, if we can get them when they're in middle school, if we can get them before they leave home, either to get a job, to go to school, whatever, if we can get them, we stand a great chance of getting them to not smoke. So the bottom line here is to get them early, and that's why we're starting in middle schools. That's why you're seeing these things on television, these public service announcements. So here's the scenario. The father, I'll use the father as an example, the father says, I'm gonna quit. Everybody's excited, everybody's getting ready. The couple of kids now say, oh, daddy, that's so great. So the father quits, and 5 days later he relapses. Now you tell me that might make him feel like a failure. So telling him that this is a problem that everybody has, that it takes between 5 and 11 times. It may take more, it may take less. And of course there are people that just toss it away cold turkey. But this is, we call, by the way, in the psychology business, we call this normalization. We all know normalization. Any of us that have kids, if that kid broke up with a boyfriend or a girlfriend, didn't make the team, didn't make baseball, didn't make cheerleading, what we say to them is, this happens to everybody. I know it's difficult now. It happens to everybody. You know, you'll get through it. That is called normalization. And that's a very powerful advice that we can give our patients. Some of the other things here, turns out repetition with tobacco cessation is very, very important. You can't do it on the first time, you can't do it second time. They may need continuous counseling until they quit. They may need to hear it from 5 different medical professionals. And this is what we're trying to do. Those of us who speak to professionals about tobacco cessation, we want everybody to do it. We want when they come into an office, at the front desk, we teach those people to give maybe a 30-second little blurb about tobacco cessation. We want the medical assistants to be trained in a couple of minute tobacco cessation thing, so that while they're doing vitals, they maybe can counsel somebody. By the way, this stuff can be done in less than 3 minutes. Basic counseling, what we call motivational interviewing, can be done in less than 3 minutes. Greater intensity increases effectiveness, brief treatments I mentioned, and counseling plus meds can double. These are some of the stages of change. I'm not going to get into them in too much detail, but you can see these are your 5 basic stages. Pre-contemplation, I have no desire to quit, no way, no how, don't bother me, I don't want to talk to you. I do not go hand to hand with those people. Okay? Basically what I'll do is I will ask permission. I'll say, and permission is key in this business, by the way, because we know, it's like people talking, you want to talk to them about their weight or their diet when they're a diabetic. And so I asked, may I ask you a question about your smoking? Okay, I realize you don't want to stop, but can I give you that one sheet? And maybe we'll talk about it next time. And they say, sure, no problem, okay. No guarantees. I said, that's fine. Contemplation is they're thinking about it, they want to quit sometime. Preparation is they're going to quit within the next 30 days. And what that means, they may clean their house, they may get rid of all ashtrays, they may get hundreds of sticks of celery and carrots ready, they may get chewing gum, or whatever the case may be. And action is when they're doing it, and maintenance is when they have quit. And then you see the other boxes there, relapse, that we actually try to get them back to the beginning. There's no reason why we necessarily have to go through all the stages. Some people want to start off right away, going back into the action phase, and we let them. And these are, there's 2 different slides I have on how basically to talk to patients for a minute or 2. And this is the U.S. Public Health Service Task Force recommendation. And this is what we call the 5 A's. And that's ask about tobacco use, advise strongly that the best thing that we can recommend to you for your overall health, okay, is that you stop smoking. We assess their interest in quitting. Where would you say you are on a scale of 1 to 10? 10 being you want to toss them right now, 0 to 1 you have no interest in the next 6 months. If they tell you they're a 5, you can work with them. They can be, because they are right on the fence. They're right what we call, they have a middle of the road ambivalence. They can be worked with. It's a little more challenging, got to do a little more work when they're less than 5. But by the way, there's an incredible advantage to asking them where they are on a scale of 0 to 10. And the reason is, in a medical record, okay, if they tell you they're a 5, you can write that down. When they come back next time and they tell you there are 3, there may be some specific reasons pertinent to their overall medical health, to their health and psychological well-being, that we may not know, that they will tell you. What? Somebody died, their neighbor died, they had incredible stresses, and that's why they dropped from a 5 to a 3. Conversely, if they went from a 5 to a 7, what happened? Well, I saw this thing on television, I got really motivated, I was watching Dr. Oz, and I decided to do it, so now I'm a 7. Putting that number in there is almost like doing a pain scale. You know, pain scale, 5th vital sign, right? It's almost like doing that. And when I teach our students, I try to reinforce it, and we put it on our medical records. Where are they in terms of their desire to quit? So it's a very valuable thing. Otherwise, you can't really put a name and face on it. You know, you say, well, where are you? Well, I'm middle of the road. Okay. And next time they come back, and you can't really assess where they are now from where they were previously. Assist them in quitting smoking. Assist may mean giving things that they could take home to read, put on the refrigerator, or it may mean getting them hooked up to a class in tobacco cessation or a program in tobacco cessation. It may also be that you're also giving them medications to get them started, and also arranging a follow-up is very important. This is sort of what I call the busy clinicians talking to a patient, and this is ask, advise, and refer. And this is similar, only it's a little quicker and a little easier. Clinicians seem to like this better. These are what we call our trigger situations. By far, the most common trigger situation that people tell me is stress. The stress clearly does it. It's stress. I smoked because of stress. I had an argument. I had an exam. I had this. I had that. That is why the counseling is so important. Because if you do not take care of their trigger, and all you're doing is handling the chemical addiction, you have only taken care of one part of this problem. Only one part. And that's why we recommend that when people use the pill for treating tobacco cessation, varenicline, and they're on that for 3 months and they stop smoking, we make sure we try to get them counseling. Because as soon as they stop that pill, if they go into a situation where they are triggered, they may start smoking again. The counseling is so important because that gets to the core of why they're smoking or why they continue to smoke, of course, in addition to the addiction. These are some questions that I like to ask if I have 3 minutes. This is my own stuff. This is not necessarily evidence-based stuff, but I like doing this. This is some of the stuff I show the med students. If I, some good questions. May I ask you about your smoking? We always ask for permission. What are the good things about your smoking? What are the not so good things about your smoking on a scale of 1 to 10? Where do you think you were several months ago? It seems like you're ready. Can we set a quit date? Quit date is very important. It tries to get them to commit to something. It seems like you're undecided. Can I help you? Can I give you this? Can we talk about it next week? A couple words about the medicines, of course. These are the different medicines. There are now 7 approved first-line medications, all of the nicotine products, and of course the 2 pills, which are bupropion as well as varenicline. We like to actually start the nicotine replacement patches maybe a week or 2 before the actual quit date. It turns out it may actually double their chances of success. Nicotine patches, we all know about nicotine patches, and this is the standard recipe for nicotine patches. I'm going to show you something else in a second. This is the PDR. This is the standard one that you read about in the books. Less than 10 to 15 cigarettes, 15 to 20 cigarettes. These are the patches you see being used. And remember, look at my last bullet there. The 5th bullet is always consider 2 different pharmacotherapies for the best results. Now, this is off-label, but a lot of places are doing this. I am also doing this to some very heavy smokers. And if you'll notice, look at the 40 cigarettes per day. That's 2 packs a day, 26 in a pack. 2 packs a day. We are recommending that they actually have more nicotine replacement than the person that's only doing 1 to 2 packs a day. You see the numbers. And I could never figure this out when I was younger. When I first started practice in 1985, I could never figure out why some of my truck drivers, the overland truck drivers, the guys that were smoking 3 packs a day, why a 21 milligram patch wouldn't do anything for them. And then it occurred to me as I became more involved in this smoking stuff, I realized that I wasn't giving them enough med to handle their withdrawal. Okay, these guys are working on a blood level of 3 packs a day. And basically, I'm giving them a 21 milligram patch when they're putting at least 40 milligrams or more. If you figure 1 milligram of nicotine per cigarette, they're putting 40 milligrams or more into their body. Nicotine gum, remember the patches, the gum, the lozenges, all OTC. The nicotine gum comes in 2s and 4s. If they're a heavy smoker, I recommend they use a 4. Remember, I'm slapping the patch on them. What we do is, if they're going to stop smoking tomorrow, Sunday morning, I put the first patch on tonight at 11 o'clock. I tell them to put the patch on at 11 o'clock. They take it off tomorrow morning at 8 a.m. and then they start their 24-hour cycle. If it turns out they're not sleeping or they're having nightmares, you don't use the patch from 11 p.m. to 7 or 8 a.m. You take it off, you let them go untended at night, if you will. The nicotine gum, they can do 1 to 2 pieces an hour. Some heavy smokers may want to do 3 pieces an hour, not at the same time, individually, of course. The way we use nicotine gum, one of the biggest errors that people make, that people don't know, it's called chew and park. Chew and park is, they chew it for 30 seconds, they park it on the inside of their gum and cheek for 30 minutes, they chew it again for 30 seconds, they put it on the other side, and then the bottom, and then after that they keep that in for another 30 minutes. You can do that with 1 piece. You obviously cut down the time if you want to do 2 pieces an hour. Chew and park. The nicotine gum is not supposed to be used like a Chiclets or like Wrigley's. It's not used that way. A lot of people, they don't understand it. When they put it in and put it in their mouth and let it sit there for 30 minutes, they get great absorption of the nicotine. Nicotine lozenges is basically the same way. We just make sure we let it dissolve and we don't, of course, they don't chew it. Nicotrol inhaler. Nicotrol inhaler is a prescription med. This is a real interesting thing. This is obviously an FDA approved. We know it's quality controlled. We know what's in there. We know how much nicotine is in there. These are little vials, little plastic ampules of liquid nicotine. This is a little, almost like the end of a Tipperillo. It comes apart. These cartridges snap in there, and they get about 20 minutes of active puffing on that. And we could use that also as a PRN with the patch in place of the gum or in place of the lozenges, if you will. It's a very, very excellent tool. Negative on it is it's expensive, and the other negative is it's menthol. So a lot of people obviously won't want to use it because it's menthol. But for a menthol smoker who has a really heavy-duty mouth-to-hand thing, it's absolutely tremendous. Nicotrol nasal spray, prescription, nobody knows about this. This actually gets squirted in the nose, like, those meds like Flonase, Vansinase, those kind of things get squirted in the nose. It's very, very powerful. It works well, but a lot of people don't like to be seen squirting stuff into their nose, obviously. So, especially in South Florida here. So, yeah, and you can see the cons there, that obviously irritation is a major negative. I spoke about double nicotine therapy. If there is one thing that you take away from this presentation today, it's double nicotine therapy and counseling. You will double your clients' chances of stopping smoking. And getting them into one of those classes is the counseling, the double nicotine. Remember, they can buy this nicotine stuff over at Walgreens, over at Costco, the patches and the gum, the patches and the lozenges, so they can do it there. The 2 other meds, obviously, are the bupropion and varenicline. Just to show you how varenicline works, remember I had this little cartoon before, and basically the varenicline actually blocks the nicotine from getting to the alpha-4 beta-2 receptor. It blocks the nicotine. So if you talk to people that have been successful on varenicline, they will tell you, I lit up, I tried to smoke, and I thought I was smoking straw or loose leaf paper. They should have absolutely no response, pretty much no response at all. If they're getting responses, then that means they have a very heavy behavioral response. And the addiction there, in addition to being chemical, of course, but the addiction may also be very heavy on the behavioral side, and you may need to focus on that. I've had people that have been on, that come to me and they've been on varenicline for 6 weeks and have stopped only, 2 cigarettes. This is obviously not working for you. And so, but that's why it's important to know that. Obviously, there are also black box warnings on these that say if they have a psychiatric history, you don't want to use it, or you want to be careful, or maybe you want to have the patient and the family sign some sort of a informed consent. But if there's a psychiatric history, I'm really careful about using varenicline or bupropion. I'm a little more comfortable with bupropion, but it all depends on the psychiatric history, of course. Couple of pieces of information on the power of intervention. Cold turkey, 2 to 4%. Brief intervention, meaning I'm talking to somebody for 1 to 3 minutes, 3 to 6%. Basically, behavioral counseling, like a class, 10 to 15, and meds and counseling could be 20 to 30. Some people say 20 to 40. Okay, just a couple of words about other nicotine delivery systems. Is there anybody here that doesn't know or hasn't heard of what a hookah is? A hookah. A hookah. Anybody? Raise your hand if you've actually, I'm really interested. If you've never heard of a hookah or a hookah bar. These are really prevalent in South Florida. Okay? And basically what a hookah is, it's basically a big water pipe. It's a very social thing for young people. I gave a presentation to dental students about 6 months, maybe a year ago, and I asked how many of you smoke? Maybe 1 or 2 smoke. This is a room full of 150 dental students, second year. How many smoke? 1 or 2, maybe 5. And I said, how many of you have been to a hookah bar in the last 90 days? I swear to you, 35 to 40% of them raised their hands. Hookah bars are all over, and what they do is it's a social thing. They go into a closed area, they sit on pillows, and they basically smoke tobacco called, they smoke tobacco, it's called a shisha, and there's different flavors and other things, and they sit around, and there may be, you see one hose here, there may be 4 or 5 hoses, and they're all puffing it. Now, or one hose that they're passing around also. There are obviously risks of infectious diseases in that situation as well, but they're in a closed area. There have been some stories, well, first of all, just to tell you, the same stuff that you get from cigarettes, you can get from hookahs. There is an increased risk of lip cancer, and they think that they ingest maybe up to 100 times more lead than in a cigarette. And obviously, a lot of people believe that this is harmless, unfortunately. This is very scary. This is from the World Health Organization in their tobacco cessation manual. And they said during a 20 to 80 minute hookah session in a closed room, what's going on there may be the equivalent smoke of 100 or more cigarettes. Okay, in a closed hookah area. Now, the bottom line, even if it's 20 cigarettes, that's still a pack. So think about it for a minute. This is, and I try to counsel these kids on it, and what can I tell you? Because it's a very social situation. A couple of slides ago, smokeless tobacco, we talk about a lot of the young people like that. We know the names, Skoal, they call it dipping. What I call smokeless tobacco is what it is, spit tobacco. That takes all the glory away from it, all the glamour. Call it spit tobacco, and that's without spitting when you're saying it, of course. But I call it spit tobacco, and that really changes the image, takes the cool thing away from it, takes the baseball player that's sitting, with the good thing on his cheek, and it takes that all away from it. And I think it's really important. Spit tobacco is, is challenging because a lot of the young people feel they're not harming anybody except themselves. If I want to harm myself, that's my business. That's why it's especially challenging in young people. Okay. Electronic cigarettes, everybody's favorite. Electronic cigarettes, of course, are a device, and you can buy it at kiosks at every mall. And there's a battery in it. There's a heating element. There is a liquid nicotine cartridge, if you will, that can be purchased or filled up from bottles, sort of like those of you that may remember fountain pens. It can be filled up from bottles. It comes in flavors, and it emits a vapor. And part of that vapor is propylene glycol. And also at the end there's a little LED red light that makes people think they're like lighting up. And this is a major, and the people that use these now, they call them vapes. And there's a big controversy over this, and a lot of people are buying it, a lot of people are using it. There's a big fear that people may use this instead of starting smoking, and this may be, you know, an introductory thing to smoking. We're also finding, I love this one, I had a lady that came into the office, she had one of these hanging from a necklace, okay? And she's sitting there, she had it hanging from a necklace. And I said, well, congratulations, you know, even though I don't agree with it because there's no evidence-based medicine behind these. I said, well, at least you're trying something, okay? I said, so when did you stop? She goes, no, I haven't stopped yet. I use this when I'm indoors. And that is the scary part of the electronic cigarettes. People are using those indoors at homes and other stuff. Obviously, there are places they can't use them. They are not supposed to be used on airplanes, on certain airlines. There are airlines that have said they, so depending on your airline, if somebody's sitting next to you and they're using one of these, you may want to ask the flight attendant. And of course they inhale it and it converts the liquid into a vapor. There is no combustion taking place. Unfortunately, there was no good data, and we're not sure. There may be carcinogens. There's not enough research out on these to know exactly what they do or don't do. We do know that several of them have exploded and caused fires and burned people. We know that. We know that there have been people that have had they've done some real minimal studies, not totally statistically significant, where they've done pulmonary functions on some people after they used this, and the people that used it had some mildly diminished pulmonary function tests. There's no quality control, and we don't know how much nicotine is in each cartridge either. This is an article, interestingly enough, that was in The Lancet in 2013, and they compared electronic cigarettes to nicotine patches and other methods. And interestingly enough, just to show you, interestingly enough, they found them comparable in helping smokers quit over a 6-month period. Some people thought they were promising, but no magic bullet. And yet, you know, the FDA at this point in time is recommending that they not be used, not be recommended, because we don't know what they do, we don't know what's in them, etc. Cigars are no bargain. They contain the same stuff as cigarettes, also increase cancer of the lung, oropharyngeal area, esophagus, increased COPD. Pipes, I also want to mention this. This was a 2004 article on pipes, and pipe smokers were shown to have increased cancers of the lung, oropharynx, esophageal. You see the others there. Just to let you know in closing that other treatments that people talk about, there's no evidence-based double-blinded studies that any of these work better than placebo. Okay, I think you'll be hearing more maybe about hypnosis and acupuncture in the future, but there are no evidence-based studies that show that right now. Cigarettes and surgery, there is no evidence that stopping cigarettes before surgery is detrimental in any way, shape, or form. There are still some people, there are still some docs that stand by the old thing, that basically they want somebody off cigarettes. I had somebody the other day, a month, I don't remember, recently, who said their surgeon told them that if they weren't off cigarettes for 3 months before, they would not do the surgery. And the bottom line is, is that may not be a bad thing, but I think withholding surgery in that situation is maybe a little bit painful to the patient. But the bottom line is, you can stop the cigarettes a week before, several days before. It's a great teachable moment. Last thing, smoking and pneumovax. A new guideline that came out from the Advisory Committee on Immunization Practices says that everybody who smokes from 19 to 65 is a candidate for pneumovax. They join the list, right? They join the list of other people like with asthma, silicosis, bronchiectasis, heart disease, diabetes, sickle cell, cancer, you name it. But this is now basically being considered a standard of care. If they are a smoker between 19 and 65, they are a candidate for pneumovax. Remember the AHEC program, they have it here. They're all free. They get nicotine replacement. We have one at Nova Southeastern. Remember, please, that this is an addiction. The smokers truly are victims. They truly are victims. This is not it's not a dirty, nasty habit. They can't necessarily pull themselves up by the bootstraps. This is not a matter of will. They can pull a plug and will to do it. U.S. Public Health Service guidelines I spoke about. the changes, the varenicline, double nicotine therapy, counseling and meds will double. And remember, any of us can say this to them, irrespective of what department you're working in, who you're working for, where you're working. Remind them that quitting smoking is the most important action you can recommend to them that they can take now to improve their health now and in the future. And I thank you so much for your attention. It's really been enjoyable. And good luck.